So I'll start with the panel in terms of one of the issues that I always have to face is some of the unintended consequences of information that we provide consumers and or patients. And I wonder what your thoughts are with respect to, again, dietary recommendations, potentially unintended consequences if one knows what their genetic risks are or background would be. And how do we achieve a balance such that we don't have dietary recommendations end up being punitive such that people feel guilty because of their choices when they know they might have a SNP that increases their risk for hypertension, for example. Anyone like to tackle that question?
So I certainly want to comment on how genetic information without genetic counseling can be very problematic. There are a number of recreational genetics companies now that will sequence various parts of your DNA and then give you DNA sequence. Of course, particularly noteworthy is the mitochondrial DNA. It's actually quite common for someone who have gotten their mitochondrial DNA sequenced by a commercial company then to go on to Google and take every nucleotide and then scan all the literature to see if that nucleotide has been correlated with any kind of clinical problem, and then call me and ask me what they should do to save themselves from this terrible disease. And I think it's really very worrisome that people, well, first of all, almost any nucleotide you can find some report that has either positive or negative consequences, as you've heard. But also, I think without appropriate genetic counseling, we're not doing people a real service to give them this kind of information.
Thank you. Tim? Oh. Tim Mork.
Hi, I'm Tim Mork with Spectrum Nutrition. Very nice morning session panel, thank you. I have a question for Dr. Wallace. We hear about weight loss and it's effective in some cases, and we heard about low protein, high protein. There's a new genre of weight loss that's talking about, in one case, fasting mimicking diets. And the process of fasting itself, of going without nutrients, tending to shift the whole metabolic baseline. And I was wondering, from the genomic standpoint, is that affecting the mitochondrial genomic process versus the anatomical one?
Well, it depends on the context in which you're asking that question. There is no question that periodic fasting changes your metabolic state, and that has repeatedly been shown in model organisms and in some primate studies to affect your longevity and lots of other risk factors. There are also clear evidence that affects mitochondrial metabolism. If you fast, you increase your antioxidant defenses, you increase your respiration rate, you make more mitochondria because they're trying to cope with low carbohydrate, then basically a fat diet from your stored fats. So there's a lot of interest in that. One of the areas that may be relevant is whether fasting increases mitophagy, and mitophagy is a way to that our bodies use to pull out the accumulation of defective mitochondrial DNA. So there's a lot of interest in the mTOR pathway and mitophagy and how that might in fact relate to longevity. But I think there's still a huge amount of unknown information that we need to really understand this in any causal way.
And also potential stem cell stimulation as well.
Absolutely. In fact, one of the most interesting studies, there's two groups have made mutations in the nuclear encoded mitochondrial DNA polymerase that increase mitochondrial DNA mutation rate. And they cause premature aging, but the main effect is that they affect stem cell biology. So yes, there's a lot of interaction there.
And just one question to the general panel. behavioral science is so important, as we've heard many of you talk about. What about the absence, or put differently, the need for better markers of improvement that are the values for reinforcing behaviors? Because I see that as so lacking today. And if we had true metabolomic panels that could show you the benefit, would that be sufficient to help motivate you to keep going?
Well, I'll comment on that one just a little bit. I totally agree. I think the behavioral feedback is really important, and this was one of the things that we were certainly trying to do in some of what we've put together with Aravel and in our Pioneer 100 study, which is basically, it's exactly this. The motivation of a disease in the far future is really not very motivating to individuals. And in fact, we don't even give people back information at present on disease risks explicitly. But the markers are exactly right. You can see that change. And so one of the things is that as you have information about what's happening in your body right now, how you've made behavior changes and how that feeds back, that's much more motivating, because it takes something that's in the far future and it actually moves it into the present. So at least in our experience, we've seen that be quite motivating for people, and they actually like to be able to see much quicker feedback than is typical.
I'd like to also make a comment. One of the big problems in clinical medicine is if we don't have a test where it's invisible to us. And in the full area of what I would like to call bioenergetic medicine, we have no good outcome variables. So therefore, it's very hard to know whether somebody has a low energy state or a high energy state, or if we give them a nutraceutical or some other kind of approach, whether it's actually having any effect. So one of the things we're spending a lot of time on is developing microelectronic and nanoelectronic systems to monitor bioenergetics in tissues, and then that would give us quantifiable outcome variables. But without that, it's going to be very hard to really do good experiments.
Dave, did you have any comments? We see you on our screen, so don't fall asleep.
I'm sorry I didn't turn it on earlier. This is a good place to bring in another point, and that is nobody really has ever accused mankind of being rational all the time. And the organ that's been left out of this whole discussion is the brain. So there's a lot of behavioral changes which are very dependent upon individuals' makeup, what drives them, what motivates them, and that then links to what would motivate them to stay in a program or to keep going a program. And it isn't always a test. Sometimes it's a feeling they have, something the way they look, the way their body image is. So that's another enormously important part of the whole equation, which usually isn't looked into very often in this particular setting.
Thank you. Next question.
Very nice talks. I have a couple of questions, one to Nat Price and one for El-Sohemy. So the first question is, you showed about this longitudinal follow-up of coaching, and at 6 months' time, you actually saw some health benefits and some of the improvement in the markers of clinical health. So have you followed them beyond that time and without coaching, like if once the study is over, if they're in the free living and no coaching whatsoever, and whether they had improved their numbers?
Yeah, we have looked at that. Yeah, a number of different things. So one, I actually want to make one comment based on what was said before, which is that I totally agree on the notion of motivation, and that measures alone are not motivating. And in fact, the whole key to what we've done with Aravel and with that program is really based on trying to help people identify true motivations, and kind of achievement of joyful moments is actually what the whole thing is about, which we could talk about, which I think is very interesting. In terms of what happens for individuals, we did sort of have a sense like this. So we did the Pioneer 100 project. A lot of those people then went into the Aerovale program, which is the commercial side of this. So we do have a couple years follow-up on them. And so we sort of had a little bit of an experiment like this, which is that there was a gap between the study and the start of the company. And we monitored for, and so a lot of the people had had a lot of improvement in the markers during the course of the study. And then during that period when they were off, when they came back on, we remeasured a lot of things. And it was interesting because many of them had reverted back and had done not so well during that period when they were not in the coaching. And then when they got back on the Airville, on the program, once it was into the company, we saw them like improve again. So it wasn't, we didn't design it that way, but in terms of just what we were able to see, we saw a lot of people that when they've come off, seem to do worse, and when they come on, they do better. So we've seen that longitudinally.
So with regard to the microbiome sequencing, was that a metagenomic sequencing?
So the microbiome there was, for cost consideration, 16S sequencing, which I think is a reasonable proxy, but metagenomics is better. I'm certainly advocating for switching to that. I like that better, but it was 16S in the study.
Could you introduce yourself, and we switch sides?
Well,
And
I'm
you have
Padma
another
Marora with
question.
NIDDK NIH. I'm a program officer. So my question about this caffeine metabolizer, slow metabolizer versus fast metabolizer, is quite interesting. But most of these like health events are not just like a single factor, right? Multifactorial. So I wondered, if you actually collected the nutritional information, just not the caffeine intake alone, or maybe what if they're taking either tea or green tea or whatsoever, and also some of the concentration of coffee, like some people drink it light, some people drink it strong, so how do you even equate all that?
Sure, that's a great question. Obviously there's a lot of factors that determine what that chemical soup looks like in terms of the coffee and the type of bean, the roasting, and how much. All of that really is adding noise because whatever the fast metabolizers are drinking or perhaps misreporting their cup sizes, the other group is probably also misreporting and drinking different kinds, the same variation. So it's not like the gene makes you prefer Arabica, which has less caffeine than Robusta. So in addition to all of the other sources of caffeine, in one of the populations, 90% of the caffeine came from coffee. When we looked at the additional sources, cola beverages and tea, the effect was still there, and the same thing in other populations. So while it's true that there are different factors that can influence the amount of caffeine and other polyphenols and other constituents, because CYP1A2, caffeine is the only major substance that we know in coffee that's detoxified by CYP1A2, that strongly implicates caffeine as a trigger.
But have you also collected the other nutrient in consumption, like what's their diet like? And
Right, so with the MI study, it was adjusted, those were multivariate adjusted odds ratios. So sugar, and in terms of what they're putting in their coffee, physical activity, smoking, all kinds of confounders, and that just altered the point estimate. It didn't affect the relative contribution of the gene, which would make sense to us.
And there are other bioactive compounds, obviously, in coffee and coffee products that could have interacted with much of this. Great. So next question.
Hi, Christy Reimers, nutrition at Conagra Brands. My question is for Nathan. I'm curious about the demographics of your population at this point, the diversity of socioeconomic status and that sort of thing, and maybe what it is now and what you're hoping it will be when you have your 100,000 or whatever your goal will be.
Yeah, great question. So the Pioneer 100 was definitely representative of Seattle, and it was in terms of ethnicity. So it's heavily Caucasian, some Asian, and smattering of other things, of other lineages. In terms of where we're at now, so with the Aerovale program being the primary way that people are, coming in, and that's, not a study, it's a company, but, we get data, from a partnership there. That is definitely heavily biased socioeconomically, and so it's so that is definitely an issue for us. We would really love to. The ethnicity, I should say, is getting broader. But there's an interesting relationship, which is that our younger people tend to be more ethnically diverse than the older. So there is some of a confounding factor in there of age and ethnicity that we have to watch for. Intuit, for example, has put their employees into the Aravale program in the Bay Area, and we got quite a lot of diversity that came from that company coming in, amongst others. So that's been interesting. We'd really love to launch this in lower socioeconomic groups. We have explored that in many ways, but the financing has always fallen through. We tried hard in West Virginia. Lee's actually gone multiple times to the Aboriginal tribes. We thought we had a deal there. We thought we had India for a while. We had an Indian billionaire that fell out at the last minute after 2 years of working on that. So we've been trying really hard to get that, but it's just a function of getting the financing for that to work. Another area that we're starting to explore is different models of payment for individuals who are very high risk for disease, where there are other parties that have financial interest in their health. And so we're trying to work on different ways where we can get that into the lower socioeconomic group. So we're thinking very heavily on that. But it has definitely been a socioeconomic, higher socioeconomic status has been a driver from cost considerations, as it is in many areas.
Thank you.
Thank you. So we have about 3 minutes left for questions. Dr. Ochoa?
I hope it's a quick question. It's for Claudia and hopefully for the others, and that is, Claudia delineated top line a pathway that determines the causality of a problem to the benefit of a clinical intervention. And could you guys talk a little bit to determine when is it that we really should be treating these very specific nutritional deficiencies, in this case, due to a pathologic release of an enzyme destroying one amino acid, or to the genetic variants that you talked in? What is the real pathway so that we can move from phenomenological observations that you so well described, saying coffee is bad or good, or genes are good or bad, to really this should be the intervention, and it's based on causality constructs?
So that's a really interesting question, and I think, because I also was involved in doing some glutamine supplementation in sickle cell disease, it becomes a question of, are we really replacing a nutritional deficiency, or is arginine and glutamine working and functioning as a drug that works for everyone? And my personal experience has been that the glutamine we were looking at impact on echo, risks for pulmonary hypertension, had the greatest effect on patients who were the most glutamine deficient, and their glutamine deficiency in their red cells correlated strongly to their tricuspid regurgent jet velocity on Doppler echo. So my bias is that the patients I'd want to target first are the patients who have the most severe deficiencies. And what we've learned from looking at the global arginine bioavailability ratio is that ratio at one point is predicting clinical outcomes years down the road. So for children, for instance, they have normal arginine levels at baseline, but they drop acutely during times of pain crisis. And we now have a phase 2 trial that shows that if you give them arginine during a pain crisis, that you have an impact on pain outcomes. When we actually looked at, because I'm assuming that it's nitric oxide bioavailability that we're affecting, but there are other pathways. When we gave arginine to sickle cell patients at baseline, we did not see an effect in nitric oxide bioavailability. In fact, there was a paradoxical decrease in nitric oxide that wasn't overcome by dose. When we gave arginine to the same patient during a vaso-occlusive pain episode, we were able to see a bump in nitric oxide. So again, I think identifying the patients who have a deficiency are probably the ones who are most likely to respond.
Jose, did you want to make the last word in 43 seconds?
Okay. My comment goes more towards the genetic component. One thing that has been criticized is that we don't have clinical proof of the benefit of that. And for example, we have been working with the PredMed study, that was a nutrition intervention study, long-term, in people with high risk of cardiovascular disease using Mediterranean diet or low-fat diet. And what we have seen is using as a gene, the TCF7L2 that is related to diabetes, that even in people that are old, 60 years and older, with high risk of cardiovascular disease, we can see a benefit of using the right diet for the right genotype in terms of reducing the number of events that took place in the 5 years of the study.
Great. Well, thank you very much. I'd like to thank the speakers for a very interesting session.